How should an SLP advocate for instrumentals? Fear should not be the reason we do something in healthcare. For many SLPs, the fear of patient harm or missing a potentially impactful diagnosis can drive home decisions that are based on irrationality, not evidence-based practice. On the flip side, even if there's legitimate concern, many SLPs are still having to fight for instrumental swallow studies. So what can we do about it? How do we successfully advocate for instrumentals without needing to shout it from the rooftops and bang our heads against the wall? As a former business owner providing instrumentals, this is a topic I'm particularly passionate about and one that I'm excited to share tips, resources, and my own personal experiences. It is much easier to get access to instrumental assessments in your building if you know how to talk the talk. If your administrator only wants to know the dollars and cents, then find that out. If they are concerned with clinical outcomes, research those too. Either one is not wrong or right, it's just how different facilities operate, and it's up to you to learn to speak their language. While this particular video will not go into all of the reasons that we need access to instrumentation for our patients, as the research is overwhelming, please check out the ASHA Practice Portal for the clinical implications of instrumental assessments if you're needing more support, and we'll link that below. Let's dive in. I'm Teresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education. Talk about clinical outcomes and how they influence payment. People in the business office at your facility might see things in a very black and white manner. Either we are making money or we are losing money. Up front, instrumentals look like money losers, but very often they are the things that save the facility a boatload in the long run. The literature is pretty clear. Without instrumentation, we do things to people they don't need or benefit from, and it's our job to educate and advocate on why that is. Also, without instrumentation, we may be wrong about the presence of dysphagia about 70% of the time, resulting in inappropriate use of thickened liquids, altered diets, strategies, and therapy. Without instrumentation, we may end up missing truly dangerous dysphagia around 14% of the time. It's a Leader 2002 study. In both cases, whether we inappropriately miss dysphagia or inappropriately identify dysphagia, there is a substantial chance the facility could be out a significant amount of money. Thickened liquids can cost a large amount of money over time, and they are not without their own issues, especially if you don't really need them. There can also be other complications if a patient is on an altered diet that can possibly lead to nutrition deficiencies or dehydration. Things like increased use of supplementation, increased chance of skin breakdown, poor patient satisfaction leading to malaise and depression, and the overuse of medications all can be very costly, especially if they're not warranted in the first place. Now let's break this down further. The thickener itself does not directly cause dehydration. However, according to Daniels and Huckabee, 2014, patients have a tendency to find thickened liquids not as palatable, therefore drinking much less than if it were a thin consistency. Well, what happens when you don't drink enough fluids? The patient is at increased risk for dehydration, malnutrition, electrolyte imbalance, sepsis, and/or a UTI, and all 5 of those conditions equate for 78% of all 30-day rehospitalizations. That's more et al. In 2010. Each time a patient is rehospitalized from a SNF within 30 days of their previous discharge, the SNF is responsible for footing the bill. So those 5 conditions can potentially cost a facility an extra $30,000. Each of those conditions have all been deemed as potentially avoidable with careful monitoring of and adherence to patient fluid and nutrient intake, and by following appropriate positioning of residents with swallowing difficulties to avoid aspiration that could potentially lead to pneumonia. Furthermore, aspiration pneumonia is the leading cause of death in skilled nursing facilities, and residents that are diagnosed with aspiration pneumonia have a mortality rate 3 times higher than the other residents. As we discussed above with the other 5 conditions, a rehospitalization due to aspiration pneumonia costs about $30,000 as well. Lastly, if your facility has many patients on feeding tubes as a way to manage dysphagia, the cost of managing a patient with a feeding tube is reported to average over $31,000 per patient per year. That's Huang 2014. On the flip side, when we miss dysphagia, we are often faced with the burden of a much sicker patient, one that may end up out of the building on a regular basis, potentially using a steady stream of antibiotics, or even the patient may die. This is what we need to emphasize to administrators and leadership, that visualizations are considered standard best practice to eliminate all of these potential scenarios. Most healthcare providers put great weight in satisfaction surveys and quality of life questionnaires. People that are unable to eat what they want to eat are typically unsatisfied, so not providing an instrumental may cost you a future referral or patient. The downsides of just doing our best at bedside are many. A friend of mine providing fees to a skilled nursing facility relayed this story to me. A facility partnered with an organization that provided nurse practitioners to skilled nursing facilities. The purpose of using the nurse practitioners was to decrease cost and overutilization of services. One day, my friend received a call from the SLP who was frustrated. There is a patient in the building that is having increasing difficulty with swallowing. The staff wants to refer to me, but the nurse practitioner in the building says all I do is refer for a swallow study. She's currently giving the patient reflux meds, and according to staff, they are not helping. My friend called this nurse practitioner and got her to finally agree to a fees. Turned out the patient had a tennis ball-sized tumor invading the upper airway space. The nurse practitioner was shaken by the entire experience, and from then on kept a steady stream of SLP referrals coming with no pushback when instrumentals were recommended. I'll be posting other videos just like this one that you won't want to miss, so make sure to hit that like and subscribe button and turn on the notification bell. Also, do you have any specific questions about advocating for instrumentals? Leave a comment below and tell me about it. We'll be sure to get your question answered as soon as possible. Talk their language, money. At retail, the price of thickened liquids cost about $1 per 4-ounce container. The skilled nursing facility, a single container of thickened liquids can cost about 32 cents. Every day, a patient needs about 9 containers or 36 ounces. It's easy to see that even with the discount when buying in bulk, thickened liquids can be expensive. So imagine if you have a skilled nursing facility with 5, 10, 20 patients on thickened liquids for no reason. This happens way more often than you think, and it happens in buildings where there are few or no instrumentals allowed. When you extrapolate this over time and consider the number of patients a facility might have on thickened liquids, skilled nursing facility might be paying an extra $10,000, $20,000, $30,000 a year that is unnecessary. Also remember, these same patients are often on altered diets and receive supplementation and vitamins to maintain their health. They may even need extra help with eating enough volume to maintain their weight. All of this becomes very expensive over time. When I was running my mobile fees company, I was called into a building that had a lot of patients on thickened liquids. The closest hospital was about 3 hours away for them to be able to get the patients out for video fluoroscopy, which obviously was very costly in transportation, and most patients just elected not to do the 6-hour round-trip ride for the swallow study. When I approached them about offering fees inside their building, they wanted me to scope everyone on thickened liquids. At the end of scoping everyone, there was only 1 patient that we found that still required the thickened liquids. Some of them had been on them for 2 years. The administrator of the building was ecstatic that we were able to get these patients off the thickened liquids and save the facility lots and lots of money in operating costs. Talk ethics, rules, and laws. It matters. So I need to bluntly say this. Instrumentation is accepted best practice. It is the standard in dysphagia care. It doesn't matter if you are in home health, skilled nursing, or acute care. We cannot treat what we have not diagnosed. If a patient's treatment plan ends up being reviewed in court and the concern being addressed is how their dysphagia was handled, you better believe one of the first questions to be asked is going to be, well, what did the swallow study indicate? What will your answer be if your patient hasn't had one? If your response would be that the administrator said no, it wasn't in the budget, then you might want to form a committee in your facility to get everyone on the same page. An SLP colleague of mine tells a story of how she was called into a court case as an expert witness and could not defend the practice of a clinician that did not get instrumentation and treated solely based on her clinical evaluation. The patient ended up passing away from aspiration pneumonia. The prosecuting attorney in the case approached the stand with Jerry Logeman's textbook in hand and asked the SLP testifying to read from that textbook, pointing to the sections that discuss why we need swallow studies to determine pathophysiology, attempting compensatory strategies, identifying aspiration, and planning treatment. There was no arguing that the patient should have received a study. Now, one question we get a lot from administrators is that, yeah, they've heard the research, but what does ASHA say about all this? One paper that you might want to share is an official statement from ASHA titled Clinical Indicators for Instrumental Assessment of Dysphagia. In this paper, they state, an instrumental examination is indicated for making the diagnosis and/or planning effective management and treatment in patients with suspected or who are at a high risk for oropharyngeal dysphagia based on the clinical examination when the patient's signs and symptoms are inconsistent with findings on the clinical exam, there is a need to confirm a suspected medical diagnosis and/or assist in the determination of a differential medical diagnosis, confirmation and/or differential diagnosis of the dysphagia is needed, there is either nutritional or pulmonary compromise, and a question of whether the oropharyngeal dysphagia is contributing to these conditions. The safety and efficiency of the swallow remains a concern. The patient is identified as a swallow rehabilitation candidate, and specific information is needed to guide management and treatment. An instrumental examination may be indicated for making the diagnosis and/or planning effective treatment in patients with suspected dysphagia based on the clinical examination and the presence of one or more of the following. The patient has a medical condition or diagnosis associated with a high risk for dysphagia, including but not limited to neurologic, pulmonary, or cardiopulmonary, gastrointestinal problems, immune system compromise, surgery and/or radiotherapy to the head and neck, and craniofacial abnormalities. The patient has a previously diagnosed dysphagia and a change in swallow function is suspected. The patient has a condition such as cognitive or communication deficits that preclude completion of a valid clinical exam. The patient has a chronic degenerative disease or a disease with a known progression or is in a stable or recovering condition for which oropharyngeal function may require further definition for management. Now, I really like this guideline because it lays out exactly when and why we should use instrumentals and leaves very little room for gray areas. One last point I want to make is that many times you hear nursing home administrators or billing office managers say that they don't want to pay for the tests because they cost money. So yes, this is true. The facility does have to come out of pocket for that test. However, the facility also receives a sum of money for Medicare in exchange for accepting that patient, and the facility agrees to provide any and all diagnostic testing out of that sum of money that the patient needs. So they are obligated to provide it, and for all of the reasons mentioned earlier, it's in everyone's best interest to do so. I've got a free gift for you over at medslpcollective.com. You'll get instant access to our free MedSLP Collective clipboard kit. We also have a robust and vibrant community of SLPs and mentors to help you out with your toughest clinical cases. Head over to medslpcollective.com now to get your hands on this. The link will be in the description below.